First topic that is there for discussion today is chemotherapy, and as we all know, chemotherapy deals with medications that are used to affect the pathological processes or the disease causing organisms preferentially and minimizing the risk to the normal physiological processes or the host tissues. So, the differential is there whenever any substance is used as a chemotherapeutic agent. It will try to modify the pathological processes or the disease causing organisms much more than hurting the host. So, in chemotherapy, we have the chemotherapy for bacterial infection, chemotherapy for viral infection, chemotherapy for protozoal infection, fungal infections and chemotherapy for malignancies. So, now let us go to various questions that have been asked in All India Institute of Medical Sciences PG entrance examination on the topic of chemotherapy. So, this drug pemetrexed you might have come across. The question is, the new agent pemetrexed useful in breast cancer belongs to which of the following category of drugs? So, this drug pemetrexed is related to methotrexate. Methotrexate we all know is an anti-folate. It inhibits the enzyme dihydrofolate reductase, therefore, preventing conversion of dihydrofolate to tetrahydrofolate, and we all know that the active form of folic acid which is useful in purine and pyrimidine synthesis is tetrahydrofolate. So, this is similar, this is a related drug, but in addition to blocking dihydrofolate reductase, this drug actually also blocks one more enzyme called thymidylate synthase, and also one more enzyme called glycinamide ribonucleotide formyl transferase. So, the three enzymes that are inhibited by pemetrexed are dihydrofolate reductase, thymidylate synthase and glycinamide ribonucleotide formyl transferase. Glycinamide ribonucleotide formyl transferase, because this same question can be asked in any PG entrance examination as pemetrexed inhibits which of the following. So, they may ask, one time it may be given as only dihydrofolate reductase, second option could be dihydrofolate reductase plus thymidylate synthase, third option could be dihydrofolate reductase plus thymidylate synthase plus glycinamide ribonucleotide formyl transferase, and the fourth one could be none of the above. So, actually it inhibits all these three: dihydrofolate reductase, glycinamide ribonucleotide formyl transferase as well as thymidylate synthase. So, these are the enzymes that are inhibited by it, and therefore, it is little bit unique because of these multiple enzymes that it inhibits. It is having superiority over methotrexate, and as any drug that affects cell proliferation will first affect the bone marrow, because the rate at which the cells in the bone marrow proliferate is quite high. So, any substance that we use to inhibit malignancy from proliferation, that same drug will also have invariably bone marrow depression as an adverse effect. So, one of the important adverse effects of pemetrexed is bone marrow depression. And how to overcome the bone marrow depression? For methotrexate, we always say folic acid is not useful, because folic acid if we give also, because dihydrofolate reductase is inhibited, it cannot get converted to active form. But in case of pemetrexed, it is peculiar, because it is not only the unique full inhibitor of dihydrofolate reductase, actually it is targeting three different enzymes, and one of those is dihydrofolate reductase, but the dihydrofolate reductase inhibition is also not full, is not complete. So, what happens is, there is still some scope for the folic acid that you give to get converted into tetrahydrofolate. Therefore, the treatment of bone marrow depression due to pemetrexed or rescuing bone marrow from the toxicity of pemetrexed will involve treatment with folic acid and vitamin B12. You need not give tetrahydrofolic acid, simple folic acid with vitamin B12 is sufficient. So, this is a slight difference. Methotrexate only folic acid will never work, whereas for pemetrexed folic acid plus vitamin B12, only folic acid also will not work, because you know there is a step where the methyl group is donated from the folate to the B12, and that B12 will again transfer that methyl group to homocysteine, and homocysteine will get converted into methionine. So, you know there is folate trap. If you give folate also, but if the person has B12 deficiency, there will not be any utilization of folate to the optimum extent. So, you need not only folate, but also B12, and therefore, here whenever you have any person on pemetrexed, it is better to give him for recovery of the bone marrow from the toxic effects of pemetrexed, both folate and B12. So, that part I think is clear. The mechanism of action, it is an anti-metabolite, and therefore, how to make the bone marrow recover from the adverse effects, give folate and B12. So, now if we go to the next question, which is an anti-metabolite out of this? Cyclosporine, methotrexate, etoposide, vinblastine. Cyclosporine is a immunosuppressant. Methotrexate is a anti-metabolite blocking the enzyme dihydrofolate reductase. Etoposide is a epipodophyllitoxin. Epipodophyllitoxin, it is an anti-malignancy alkaloid, and these epipodophyllitoxins are topoisomerase inhibitors. So, it is not a anti-metabolite. Anti-metabolites are those substances which interfere with the purine pyrimidine synthesis, or which are themselves analogues of purine and pyrimidine, therefore, they interfere with the effective formation of DNA or the products of DNA. So, anything that is impairing the nucleotide formation or disrupting the function of normal nucleotides, then it is called an anti-metabolite. Why methotrexate or pemetrexed come under anti-metabolite is because they are having some role in preventing the formation of the nucleotides, and the nucleotides, if they are not formed, you will not have a normal replication of the DNA. If replication of the DNA does not happen, it will not allow the cell to proliferate or replicate, and if the cell cannot proliferate, obviously the cell count falls and the malignancy is said to be under control. So, that is how we call them as anti-metabolites. Vinblastine is a vinca alkaloid, and its mechanism of action is through inhibition of the tubulin polymer, which is responsible for formation of the mitotic spindle. So, neither cyclosporine nor etoposide nor vinblastine is having anything to do with the nucleotides. The only substance which interferes with the nucleotide formation here is methotrexate. Therefore, methotrexate is an anti-metabolite. Now, if we see this drug, ifosfamide belongs to which group of anti-cancer drugs? Ifosfamide is a alkylating agent. And what do we mean by an alkylating agent? An alkylating agent is a substance which donates the alkyl group. Now, who picks up the alkyl group? Ifosfamide is ready to give the alkyl group, but who will pick up that alkyl group? That alkyl group is actually picked up by nucleotides in the DNA. Normally, we all know that A will combine with T and G will combine with C. A, T and G, C combinations we have in the nucleotide, which maintain the double helical structure of the DNA. But if A is linked to G or G is linked to G and T is linked to T, then the whole 3-dimensional geometrical structure of the DNA will be distorted, it will collapse. So, that is what is actually done by the alkylating agents. They go and attach to guanine and cause attachment that guanine with another guanine. They will attach to adenine and make attachment to another adenine. They go and attach to thymidine and attach to another thymidine. So, they cause all type of unnecessary cross linking, which is unacceptable, and therefore, the DNA loses its capability to perform the normal function, and these are called cell cycle non-specific agents. All alkylating agents are cell cycle non-specific, whether the cell is proliferating or not proliferating, whether it is in the dormant stage or the proliferative stage, any stage they will act, and therefore, they are highly toxic substances. Some other drugs like anti-metabolites, they will act more when the cell is proliferating, because the DNA replication will not regularly take place, it will take place only when the cell is having a high rate of proliferation. So, their effect will be seen more in tissues which high rates of proliferation, as seen in malignancy. So, the difference between benefit in malignancy and adverse effect will be more in case of drugs which are having a selective action and which act on cells which are proliferating, but unfortunately, these are cell cycle non-specific agents. Alkylating agents do not have any specificity. They will act on the cells which are dormant as well as the cells which are proliferating, and majority of our cells in our body will not be proliferating at exaggerated rates. So, all those tissues also will be covered under the toxicity of these alkylating agents, and one of the important risks of alkylating agents is alkylating agent themselves increase the risk of tumors. they can themselves increase the risk of malignancies. That is one of the important adverse effects. The precursor of ifosfamide, which we used to use, cyclophosphamide. Cyclophosphamide, ifosfamide are two alkylating agents which are actually prodrugs. Sometimes this question can be reframed as all of the following about ifosfamide are true except. So, ifosfamide is a prodrug, cyclophosphamide is a prodrug. In the liver they get converted to intermediary compounds, something like an aldehyde. For example, cyclophosphamide and ifosfamide they get converted to aldophosphamide and phosphoramide. So, they are aldehyde derivatives and they are in a position to donate their alkyl radicals to the guanine, thymine, adenine or cytosine and cause cross linking and collapse of the DNA. Very, very toxic compounds. One important problem with both cyclophosphamide and ifosfamide is both of them, one of their metabolites is acrolein, and that acrolein is filtered at the glomerulus and it enters into the bladder. It is an irritant to the transitional epithelium lining the bladder and it will cause hemorrhagic cystitis. So, that is the biggest problem with this ifosfamide and cyclophosphamide. But there is a method by which we can overcome this hemorrhagic cystitis. There is a compound called as MESNA, mercaptoethane sulfonate, MESNA, mercaptoethane sulfonate. It has got SH groups in its structure and these SH groups they mask the acrolein, which is responsible for triggering free radical mediated injury to the bladder epithelium. So, MESNA should be given with the ifosfamide and cyclophosphamide to limit the hemorrhagic cystitis adverse effect of these two compounds. So, ifosfamide is an alkylating agent and briefly I will tell you all drugs generally have anti-malignancy drugs have adverse effects which are related to bone marrow depression unless until specified. Some of them may not have, but 90% of them will have adverse effect on the bone marrow, will have effect on the hair follicle, will have effect on the skin and mucous membranes and the GIT, they have effect on the gonads, they have effect on the immunity. So, these adverse effects minimum you should remember, they will cause bone marrow depression, they will cause alopecia, they will cause mucositis, they will cause mucosal ulcerations and bleeding from the GIT, they will cause infertility, they will cause risk of bacterial, viral, fungal infections, protozoal infections secondary to immunosuppression, and these also increase the risk of malignancies, because the immunological surveillance in our body which takes care of rogue cells which become uncontrolled and start to proliferate excessively, those are also taken care of by some of our immunological cells only, especially the natural killer cells. But these cells they are non-specific, these drugs these are non-specific, cyclophosphamide, ifosfamide, they will kill even those cells which are responsible for immunological surveillance against malignant cells. So, there is increased risk of malignancy also. So, these are general side effects. Additional side effects are nausea, vomiting, because these substances cause so much amount of tissue destruction, and tissue destruction will lead to release of serotonin and some other neurotransmitters, and they will cause reverse peristalsis and initiate nausea and vomiting. So, nausea, vomiting, bone marrow depression, alopecia, then increased risk of infections due to immunosuppression, gonadal suppression, infertility, secondary malignancy. These are minimum adverse effects that you can expect from these compounds. And additionally, some drugs have exclusive side effects like cyclophosphamide, ifosfamide. In addition to all this, they have that hemorrhagic cystitis. Now, they are not ifosfamide is not an antimetabolite, it is not a mitotic inhibitor. The mitotic inhibitors are taxanes and vinca alkaloids. Taxanes and vinca alkaloids, they are mitotic inhibitors. Then topoisomerase inhibitors. Topoisomerase inhibitors are etoposide and tenofoside. And topotecan, irinotecan. Topotecan, irinotecan, etoposide, tenofoside, they are topoisomerase inhibitors. Now, oligozoospermia is caused by methotrexate, hydroxychloroquine, leflunomide, dipencilamine. So, oligozoospermia is caused by which of the following? Leflunomide causes, dipencilamine causes, hydroxychloroquine causes or methotrexate causes? Which of do you think will cause oligozoospermia? Methotrexate, classically no one describes oligozoospermia because the difference is there in terms of ability of methotrexate to inhibit the pathological processes more than the physiological processes, because methotrexate gets concentrated in the malignant cells 50,000 times more than in a normal cell. Now, if you see hydroxychloroquine is an anti-inflammatory compound. It does not really have much involvement on the rate of proliferation of some cells. So, hydroxychloroquine is typically used in DMARD as a rheumatoid arthritis. It does not cause. Leflunomide is a agent which is again used in rheumatoid arthritis. It is a dihydroorotate dehydrogenase inhibitor, and it may lead to some amount because it is a pyrimidine synthesis inhibitor. It may cause. Now, D-penicillamine is a chelating agent. It is used for chelation of copper, and it has adverse effects like nephrotic syndrome. This is one of the drugs. This has adverse effect like causing pyridoxine deficiency. So, if at all you have to choose from this, methotrexate, hydroxychloroquine, leflunomide, D-penicillamine, answer you should choose as leflunomide. Here it is written as methotrexate. Oligozoospermia with methotrexate is not very common. Methotrexate adverse effects are bone marrow depression. Methotrexate adverse effects are pulmonary fibrosis. Methotrexate adverse effects are hepatotoxicity. Methotrexate adverse effects are mucositis. Leflunomide can cause infertility. Which is not an alkylating agent? 5-fluorouracil, chlorambucil, melphalan, cyclophosphamide. Chlorambucil is an alkylating agent, melphalan is an alkylating agent, cyclophosphamide is an alkylating agent, whereas 5-fluorouracil is an antimetabolite, because 5-fluorouracil will get converted to 5-fluorodeoxyuridine. 5-fluorodeoxyuridine will inhibit thymidylate synthase, and therefore, thymidylate synthase, if it is inhibited, thymidine will not be formed. If thymidine is not formed, one of the nucleotide is not formed, by definition that we discussed earlier, if one of the nucleotides is affected, it is not formed, then it is antimetabolite. So, antimetabolite is 5-fluorouracil, whereas chlorambucil, melphalan, cyclophosphamide, all three are alkylating agents. Chlorambucil is used in chronic lymphocytic leukemia, melphalan is used in multiple myeloma, cyclophosphamide used in most head and neck cancers. Methotrexate resistance occurs by depletion of folate, overproduction of dihydrofolate reductase, deficiency of thymidylate synthase, deficiency of thymine kinase. What happens is, if you keep on giving methotrexate, the cells they will start to produce more amount of dihydrofolate reductase. Of course, there are many other mechanisms. The methotrexate resistance also occurs to some extent by alternate mechanisms by which the organism can still survive without folate. It can also pump out folic acid. So, many mechanisms are there, but the most important mechanism is the dihydrofolate reductase will be overexpressed. So, whatever methotrexate we are giving will not be able to inhibit all of the dihydrofolate reductase. All are true about ifosfamide except, now it is a nitrogen mustard, that is true. It is metabolized by CYP3A244 active metabolite. In the earlier slides we discussed, it is a prodrug. Chloral acetaldehyde is the active form, that is what I told, one of the intermediates that is formed is an acetaldehyde, less neurotoxic than cyclophosphamide. There is no difference in terms of neurotoxicity between either cyclophosphamide or ifosfamide. Bleomycin toxicity is characterized by destruction of. This bleomycin is peculiar because it damages the type 1 pneumocytes in the lung, and you all know that the type 1 pneumocyte, once it is damaged, cannot be replaced. The type 1 pneumocyte do not have the ability to proliferate. So, when the type 1 pneumocytes are damaged, if they are lost, they will be tried to be replenished or replaced by the proliferating type 2 pneumocytes, and in this process there will be inflammation, and that will lead to pulmonary fibrosis. So, one of the important adverse effects of bleomycin toxicity is pulmonary fibrosis. So, here toxicity is characterized by destruction of the type 1 pneumocytes of the lung. Given to prevent side effect of pemetrexed, I discussed in the morning earlier slides, folic acid and vitamin B12, that is the combination that we use. Least emetogenic drug is, most anti-malignancy compounds are emetogenic, most emetogenic anti-malignancy compound is cisplatin. Cyclophosphamide is also quite emetogenic. Now, if you can see here cisplatin, doxorubicin, daunorubicin, chlorambucil, here out of that least emetogenic they are asking. So, cisplatin is quite emetogenic, doxorubicin, daunorubicin is quite emetogenic, cyclophosphamide will be emetogenic, chlorambucil is less emetogenic. So, this you have to just remember, chlorambucil is less emetogenic out of all that are listed in this slide. Most emetogenic is cisplatin. 58-year-old woman has been diagnosed with locally advanced cancer of the breast and has been recommended for chemotherapy. 5 years history of myocardial infarction and congestive heart failure. Which anti-neoplastic agent should be avoided? So, any anti-neoplastic agent which is cardiotoxic should be avoided, because she has had MI and post MI she is having now congestive heart failure. So, if congestive heart failure is there, there is stretching of the myocardium, there is increased risk of conduction abnormalities, there is increased risk of cardiac arrhythmias, and not only that, there may be actually precipitation of congestive heart failure if the drug is also going to injure the myocardial fibers. So, the drugs which generate free oxide radical and not only kill cancer cell, but go and also destroy the myocardial fibers in the heart are anthracycline antibiotics. The anthracycline antibiotics are doxorubicin, daunorubicin, idarubicin. Doxorubicin, daunorubicin, idarubicin and mitoxantrone. But out of these, doxorubicin, daunorubicin, idarubicin, they all have the cardiotoxic potential. Mitoxantrone has least cardiotoxic potential. So, that you should remember. The anthracycline antibiotic which does not have much cardiotoxic potential is mitoxantrone, mitoxantrone. But the adverse effect of mitoxantrone is, mitoxantrone produces bone marrow depression. Neither doxorubicin nor daunorubicin or idarubicin have that bone marrow depression as adverse effect, but mitoxantrone has bone marrow depression as adverse effect. And not only that, mitoxantrone is also known for discoloring skin and mucous membrane bluish. It will discolor the skin and mucous membrane in blue tinge. So, this is important, and not only that, anthracycline antibiotics are also radiation sensitizers. They can cause radiation recall syndrome. For example, if some person has been subjected to radiotherapy in the past and suddenly now you start them with the doxorubicin, daunorubicin or idarubicin or mitoxantrone, they will experience acute radiation sickness. So, it is called radiation recall that is associated with these compounds. So, the important points are doxorubicin, daunorubicin, mitoxantrone, these are cardiotoxic. How cardiotoxic? They are cardiotoxic as both those which cause biochemical alteration by free oxide radical mediated injury to the fiber. They can affect the electrophysiological properties of the fiber, and if they are given in large doses cumulatively, they can also affect the structure of the myocardial fiber and lead to precipitation of congestive heart failure. And not only that, they are also radiation recall inducers. If they have already received radiation some time back within a very short period of time, if you give them these compounds, they may have precipitation of acute radiation sickness. And mitoxantrone, you remember, is the anthracycline analog or anthracycline derivative which has least cardiotoxicity. Peripheral neuropathy may occur with the use of all of the following except vincristine, cisplatin, L-asparginase, procarbazine. Vincristine will cause, cisplatin will cause, procarbazine will cause, L-asparginase does not cause neuropathy. L-asparginase is an enzyme which is used, and you know aspargine is an enzyme, asparginase is an enzyme, and aspargine is essential for the malignant cells. Normal cells, they do not require aspargine, they can actually synthesize aspargine, but the malignant cells, they have to get aspargine, and therefore, this asparginase enzyme is working very aggressively in the malignant cells to form So, this asperginase if you give, it will destroy the aspergine and the malignant cells will not have aspergine, and because of which they will not be able to proliferate. Aspergine is essential, quite essential for the rapidly proliferating cells. The moment you give asperginase, that asperginase will break down the aspergine. So, it is having least toxicity out of all anti-malignancy compounds we use, but then tolerance and resistance develop very rapidly, because the proliferating cells, they develop mechanisms by which they can proliferate even in the absence of aspergine. So, that is why as a monotherapy it is not very successful, but toxicities are very, very few. Procarbazine, dacarbazine, can you remember where they are used? Procarbazine is a part of the MOP regime, meclorithamine, oncovin, prednisolone, procarbazine for Hodgkin's lymphoma, and its congener, procarbazine's congener dacarbazine, is used in malignancies associated with the skin, malignant melanoma. A patient with cancer received extreme degree radiation toxicity. History revealed the dose adjustment of particular drug was missed during the course of radiotherapy. Which of the following drugs required a dose adjustment in that patient during radiotherapy in order to prevent radiation toxicity? Vincristine, dactinomycin, cyclophosphamide, mercaptopurine. Here again actinomycin D. Actinomycin D also is a potential radiotoxic agent. So, actinomycin D is also called as dactinomycin. So, the dose of dactinomycin or actinomycin D has to be very much reduced if you are planning for sensitizing someone to radiotherapy. And one important use of actinomycin D, if you can remember, one PG entrance question is, you know what is the mechanism by which anti-malignancy antibiotics act? If you take actinomycin D, how does it act? These are drugs which go and bind anywhere in the DNA helix, and just as alkylating agents that we have discussed, which cross link adenine to adenine, thymine to thymine, guanine to guanine, which is unacceptable. A should link to T, G should link to C. Same way, these anti-malignancy antibiotics also are called intercalating agents. They will cross link nucleotides which should not be cross linked, and therefore, the DNA collapses. Highly toxic malignant compound, anti-malignancy compounds, these are anti-malignancy antibiotics. Now, all of you know what is the drug used in treatment of choriocarcinoma. Most of you know, Methotrexate. But if someone asks you what is the treatment of choice for choriocarcinoma not responding to Methotrexate, the answer is actinomycin D. And of course, you might have read about Wilms tumor of the kidney. One of the drug used in treatment of Wilms tumor of the kidney is actinomycin D. So, that you should remember. Which of the following statements is false regarding vincristine? Vincristine is an alkaloid. At the beginning I started, vincristine is a vinca alkaloid. Vincristine, vinblastine. Did you ever see vinca plant? It is seen mostly growing wildly, unintentionally, wherever you have some wild plants, shrubs growing. If you have seen Satoskar textbook, there is one plant image drawn on that, one flower is there, that is the vinca flower. So, if you see that, you know that that is what regularly you see on the sides of the road, that is the vinca plant. So, these are mitotic agent inhibitors, they go and block the beta tubulin fibers which are responsible for forming the mitotic spindle. So, vinca alkaloids are, we know vincristine is an alkaloid. It is used associated with neurotoxicity, we know that it is used associated with neurotoxicity. One of the important adverse effects of vincristine is neurotoxicity. It does not cause alopecia, that is really surprising. Which one of the following statements is false? It does not cause alopecia is unacceptable, because any drug which inhibits mitosis will inhibit mitosis of all rapidly proliferating cells, including the rapidly proliferating hair follicle. If the hair follicle is affected, person will have alopecia. So, it does not cause alopecia is not correct. It is a useful drug for induction of remission in acute lymphoblastic leukemia, correct. It is one of the important drugs used in induction of treatment in acute lymphoblastic leukemia, along with the methotrexate it is used. So, now which is false? It is not associated with alopecia is false. Why vincristine causes neurotoxicity? It is because vincristine's mechanism, if you look at, it is affecting the tubulin protein. the tubulin protein which is responsible for forming the mitotic spindle. So, the tubulin protein is not only responsible for forming the mitotic spindle, the tubulin protein is also a part of all the neurons. You know, whenever there is a neuron, we discuss the structure of a neuron as having a cyton and an axon. So, whatever nutrients are there in the cyton, how they go to the axon terminal? They flow from the cyton to the axon terminal. How do they flow? They flow via the help of tubulin proteins. These tubulin proteins maintain the flow of the nutrients along the exoplasm from the cyton to the most peripheral portions. Now, when you give this compound which is acting on the tubulin protein will not be able to transfer the nutrients effectively from the cyton to the periphery. So, that is why mostly we get peripheral neuritis or central neuritis. Peripheral neuritis, because the peripheral portions of the neuron are more dependent on the working of the beta tubulin. If the tubulin protein does not work, the first tissue that will suffer with the lack of nutrients reaching it from the cyton is the peripheral area. If you are staying very close to a water tank and some people receive the water from the water tank through pipes, if the pipe is disrupted, the people living close to the tank will be affected more, or the people living farther away from the tank will be affected more? Farther away, because they depend on the pipe. So, here also the parts of the neuron that are very close to the cyton will affect less, whereas the part of the neuron which are very far away from the cyton, they will suffer more, because they will depend on the tubulin protein for the transfer of the nutrients. So, that is why any drug which is affecting the mitotic spindle is indirectly affecting the beta tubulin, is also affecting the neuron, and that is why vincristine causes neurotoxicity. Which of the following chemotherapeutic drug has selective action on hypoxic tumor cells? Mitomycin C, cisplatin, doxorubicin, 5-fluorouracil. So, cisplatin, doxorubicin, 5-fluorouracil. Cisplatin is a platinum coordination complex. It will directly go and chelate, and actually in fact it will go and bind to the DNA because of its positive charge, whereas doxorubicin is a free oxide radical generator and it will require oxygen. So, it cannot act in a hypoxic environment. Then 5-fluorouracil. 5-fluorouracil is an antimetabolite. It will go and block the thymidylate synthase enzyme. So, it has nothing to do with hypoxia. So, all these three by elimination, they have nothing to do with hypoxia, whereas mitomycin C, in case of hypoxia, the DNA where it becomes very susceptible, mitomycin goes and damages it further by binding to the guanine or thymine or cytosine or adenine and cross linking. So, mitomycin C acts in even hypoxic tumor cells. Chemotherapeutic agent most commonly administered by continuous infusion is, so arabinosides, cytosine arabinoside or 5-fluorouracil, cisplatin, etoposide. All of them can be given, but the most commonly used as continuous administration or infusion because of its short half life is cytosine arabinoside, also called as ARA-C. This is only one point about the cytosine arabinoside, continuous IV infusion because of a short half life. One important thing about AIMS questions is at least 60% of them are repeated in the next exam, at least 60%. And you know what will be the highest marks in AIMS exam? 60%. Out of 200, highest will be 120, 130 only. And people generally do not believe when they see the papers, 50 to 60% of AIMS questions are always repeated. They will make small changes here and there. So, you should not forget that whenever something is given, it may not come again, it will come, but only thing is they may make a small change, they may ask something one sentence before that or one sentence after that in the textbook, whatever is there. So, cytosine arabinoside you should remember for this. Sustained neutropenia is seen with vinblastine, cisplatin, carmustine, or of course, other option you can take as vincristine. They are not written. So, this is very significant. Carmustine is a nitrosourea, lomustine, cimustine, carmustine, they are called nitrosoureas. This is very typical, prolonged neutropenia. Why carmustine, simustine, lomustine produce prolonged neutropenia? There is a reason for this. Carmustine, simustine, lomustine, they are nitrosoureas. One hallmark of nitrosoureas is nitrosoureas are highly lipid soluble. Because they are highly lipid soluble, they are having high tissue distribution. They will go and sit in the tissues for a long period of time. You know that any drug that is highly lipid soluble will be deposited in most tissues. They will have high volume of distribution. They will be slowly metabolized and eliminated. So, if I have received lomustine, simustine or carmustine, I will have the drug staying in my body for a long period of time. Therefore, the effect of this drug on the bone marrow will be for a long period of time, and therefore, it will cause prolonged neutropenia. Because these drugs are highly lipid soluble, they can easily cross the blood brain barrier, and one of the important use of these compounds is in treatment of central nervous system tumors, of the central nervous system. There is one more alkylating agent which is very much preferred in the treatment of central nervous system tumors, because it can easily cross the blood brain barrier, temozolomide. Temozolomide is one alkylating agent which is preferred in treatment of central nervous system tumors. Which of the following is not an alkylating agent? Cyclophosphamide, busulfan, 5-fluorouracil, melphalan. Cyclophosphamide, busulfan, melphalan are all alkylating. 5-fluorouracil is an antimetabolite. Which of the following is an anti-cancer drug excreted by the lungs? Cyclophosphamide, doxorubicin, cisplatin. Bleomycin, busulfan, 5-fluorouracil, they are all excreted by the lungs. So, 5-fluorouracil here it is listed, it is excreted by the lung. One more thing about 5-fluorouracil which will be asked in the examination is, normally when you give folic acid, for example, folic acid and B12 are given to rescue the bone marrow from the side effects of pemetrexed that I told at the beginning of the lecture today. So, now if you see what will happen, why folic acid if you give to a patient with 5-fluorouracil, what will happen, whether toxicity will improve or no effect or toxicity will be less. If I give 5-fluorouracil with folic acid, the effect of 5-fluorouracil will increase as a chemotherapeutic agent, or its adverse effect will be less, or there won't be any benefit or no harm. Folic acid if you give with 5-fluorouracil, anti-malignancy action of 5-fluorouracil will be enhanced. This is a AIIMS question. Why folic acid enhances 5-fluorouracil's anti-malignancy action is, you have to go back to the mechanism of action of 5-fluorouracil. 5-fluorouracil gets converted to 5-fluorodeoxyuridine monophosphate. That 5-fluorodeoxyuridine monophosphate will become 5-fluorodeoxyuridine triphosphate. 5-fluorodeoxyuridine triphosphate is a substrate which goes and bind to thymidylate synthase, and therefore, thymidylate synthase will get blocked. If thymidylate synthase is blocked, it can't form thymidine. If it can't form thymidine, the cell will die thymidine-less death, because for the DNA to replicate, it will require thymidine. So, DNA will not be able to replicate. So, the 5-fluorouracil, whenever it is binding to thymidylate synthase, its affinity for thymidylate synthase will be very much enhanced in the presence of folic acid. So, if you give 5-fluorouracil, if you give folic acid, thymidylate synthase inhibition will be enhanced, and because it is enhanced, you will have greater anti-malignancy action and therefore, greater toxicity also. But if you want to recover from the bone marrow's adverse effect of 5-fluorouracil, you can give thymidine. That is the only way, because you are blocking synthesis of thymidine. If you have to treat 5-fluorouracil toxicity, you have to go one step beyond. So, you have to directly give thymidine. So, that is the only way in which you can save some excessive dosage from 5-fluorouracil. So, you should be careful. For methotrexate bone marrow induced toxicity, we use folinic acid, but for 5-fluorouracil, what will happen if you give folic acid? It will enhance the toxicity of 5-fluorouracil. It will improve the anti-malignancy profile of 5-fluorouracil. This, because not many textbooks have highlighted, many students write it wrong in the exam. They all think that by giving folic acid, you will be reducing the toxicity of or effect of 5-fluorouracil, that does not happen. If you want to make 5-fluorouracil act more efficiently to kill more malignant cells, then give 5-fluorouracil with folic acid. Then again, most emetogenic drug is, as we discussed, cisplatin is the most emetogenic. Later comes cyclophosphamide, ifosfamide, doxorubicin, daunorubicin, in that order. Cisplatin, cyclophosphamide, ifosfamide, doxorubicin, daunorubicin. Cisplatin is most emetogenic. Cerebellar toxicity is seen with, there are quite a lot of compounds which cause cerebellar toxicity, ataxia they will cause. Here it is cytarabine. Of course, 5-fluorouracil also can cause, gemcitabine, capcitabine also can cause. So, 5-fluorouracil, gemcitabine, capcitabine, cytarabine, but most important one which can cause this cerebellar ataxia is cytarabine. What is the difference between 5-fluorouracil, capcitabine and gemcitabine? Are they related or unrelated? 5-fluorouracil, capcitabine and gemcitabine are related. 5-fluorouracil is given parenterally. It does not have oral absorption significantly. Therefore, people made some changes into the structure of 5-fluorouracil and they made capcitabine and gemcitabine, which can be given orally. In the liver, they go and get converted to active 5-fluorouracil. So, capcitabine, gemcitabine are actually prodrugs of 5-fluorouracil. Cytarabine, 5-fluorouracil. 5-fluorouracil, another important side effect is foot and mouth syndrome. The skin and mucous membrane excoriation is common with 5-fluorouracil usage, with gemcitabine, capcitabine usage. So, they may cause ulcerations in the mouth and also excoriation of skin in the hand and foot, hand foot mouth syndrome. All are alkylating agents except 5-fluoromelphalan, of course, this is very simple repetition again. 5-fluorouracil is not an alkylating agent. Most common dose limiting toxicity of chemotherapeutic agent is, unless until specified, I began saying that one of the tissues in the body which has got tremendous rate of proliferation and which is therefore susceptible to all anti-malignancy drugs is the bone marrow. So, bone marrow depression is the most important toxicity of most compounds unless and until specified. Drug used in estrogen dependent breast cancer. So, block the estrogen receptor, anti-estrogen, tamoxifen. Now, regarding tamoxifen, this simple type of question may not come. Most of the time a little difficult question comes. So, you should know everything about tamoxifen. So, tamoxifen is a estrogen antagonist, but it is a selective estrogen receptor modulator. It will block the estrogen receptors in the breast, but unfortunately it is an agonist at the estrogen receptors in the endometrium. So, if the woman is having intact uterus and you are giving tamoxifen, if she is having breast cancer cells will be blocked. They will not be allowed to grow under the influence of estrogen because tamoxifen is blocking the estrogen action in the breast, but it will continue to stimulate the endometrial estrogen receptors and it will lead to endometrial proliferation, endometrial carcinoma. So, the risk of tamoxifen is endometrial carcinoma. So, if woman is hysterectomized, it is safe, but if woman has intact uterus, we should be careful with tamoxifen because it increases the risk of endometrial carcinoma. And not only that, there are other deeper questions associated with tamoxifen. See, for example, there is a postmenopausal woman who has estrogen receptor positive breast cancer. Postmenopausal woman has estrogen receptor positive breast cancer. Can tamoxifen be used or not? Now, that is used. Okay. If you have a premenopausal woman who has a breast cancer, can tamoxifen be used or not? It can be used. If a woman does not have breast cancer, but there is a strong family history, her mother has, her two sisters has. So, can she take tamoxifen prophylactically? It is used. It is used prophylactically if there is a and she is also BRCA 17, BRCA 22 positive. So, then you should use. So, it is not only used for treatment, it is also used for prophylaxis. So, it is used for treatment, it is used for prophylaxis, it is used in premenopausal, it is used in postmenopausal. So, those are the things that are there with tamoxifen. It is used in premenopausal women, it is used in postmenopausal women, it is used in prophylaxis, it is also used in treatment. Can it be used in estrogen negative receptor cancer? Estrogen receptor negative cancer. We all know that estrogen receptor positive cancer we can use tamoxifen. Can it be used in estrogen receptor negative cancer? It can be used in estrogen receptor negative cancer also. So, therefore, now it is said that there are mechanisms other than estrogen receptor blockade that are responsible for tamoxifen's action. Clinical trials show that tamoxifen is beneficial even in women who are having estrogen receptor negative cancer. So, there is obviously some mechanism to tamoxifen which is beyond blocking estrogen receptors. So, these are the points about tamoxifen. It can be used in estrogen receptor negative, it can be used in estrogen receptor positive, it can be used in premenopausal with cancer, it can be used in postmenopausal women with cancer, it can be used not only for treatment, it can also be used as prophylaxis of cancer. So, these many points are there about tamoxifen on which one or the other PG entrance question definitely framed. And tamoxifen can cause endometrial cancer. And not only that, tamoxifen in the long term, before it can cause cancer, it can cause visual abnormalities also. Cataract can be caused, retinal degeneration can be caused, all these are there. So, we should know thoroughly about tamoxifen. Methotrexate is used in all except sickle cell anemia, psoriasis, rheumatoid, ankylosing. In psoriasis, rheumatoid arthritis, ankylosing spondylitis, it is used. Sickle cell anemia, the condition is where the beta globin chain of hemoglobin, instead of glutamic acid, there is valine. So, that we cannot change with methotrexate. So, methotrexate has no role in sickle cell anemia. Topical mitomycin C is used in the treatment of basal skull carcinoma, tracheal stenosis, skull base osteomyelitis. And see, mitomycin C is a powerful anti-proliferative agent, I told you, because DNA for its proliferation, it requires intact strands. If you give mitomycin C, it will go and block the strands in whichever way it likes, and the whole DNA 3-dimensional geometric structure collapses abruptly. So, fibroblast proliferation in case of tracheal stenosis can be stopped effectively by giving mitomycin C. In fact, mitomycin C drops are used in preventing scarring at many sites. One of those sites is in the trachea, because scarring anywhere is okay, but in the trachea it is dangerous, people will not be able to breathe. Topical mitomycin C in aggressive proliferating pterygium also it may be tried. And apart from that, which other drug is used in pterygium, which is an anti-malignancy drug? Thiotepa. Thiotepa is used in proliferating pterygium. Pterygium is of two types, no? One is stationary and other is progressive. The progressive pterygium will keep on impinging towards the limbus, it will go beyond the limbus, it will go toward the pupil, and then the person will not be able to see anything. So, you know the Macronald's operation, where the growing end of the pterygium is removed and put under the subconjunctiva in the upper or lower lid, and to prevent recurrence we put Thiotepa drops. Use of tamoxifen for breast cancer can cause all of the following adverse effects except thromboembolism. It will cause thromboembolism because it is an estrogen agonist in the liver. So, in the liver it will increase the formation of the clotting factors, it will increase the risk of deep vein thrombosis, it will increase the risk of thromboembolism. Endometrial carcinoma, we discussed, it is an agonist. Carcinoma in the contralateral breast, it can't aggravate the contralateral breast cancer, it is not having that potential. Cataract, it can cause, as we discussed, ocular toxicity. So, if a woman has breast cancer on the right side, if it is protective there, obviously it will be protective on the left side also. It can't cause more growth of cancer on the right, because it is a blocker of the estrogen receptor. So, estrogen receptor related cancer or non-estrogen receptor related cancer, in the breast it is protective. So, if one breast is having, the other breast will have cancer is absolutely wrong. Which of the following is used to treat hormone responsive breast cancer? Cyproterone, clomiphene, diethylstilbestrol, tamoxifen. So, here hormone responsive in the sense estrogen receptor positive. So, tamoxifen. There is no role for androgen receptor blocker cyproterone, there is no role for clomiphene, there is no role for diethylstilbestrol. Diethylstilbestrol will in fact aggravate cancer. Amifostine is a drug which is used to alleviate or overcome the free oxide radical injury mediated by radiation. So, once any radiation has been given, the radiation will generate so much amount of free oxide radical that you need some free oxide radical scavengers. So, free oxide radical scavenger drug is amifostine. So, it is a radioprotector because it will scavenge the free oxide radicals that are generated as a result of radiotoxicity. So, it is the radioprotector, and one of the important toxicities of amifostine or side effects of amifostine is hypotension. It is a vasodilator and it can cause significant hypotension. It can cause myocardial depression also. So, whenever anyone is receiving this amifostine, you should monitor for blood pressure.